all webcams on. Yeah, so that we're actually looking at people, not at a black screen. Thanks.
Okay, so I'm going to be in room 5 as well. Great. I'll open all the rooms now.
Oh, hang on. We're all here. We can have the class photo before we all get messy. So, can you look directly at the camera? Look at the webcam. Louisa, yeah, can you just adjust that so your face is in the thing? All right. 3, 2, 1. Smile. And I've got it. Okay, carry on.
Right. All right. I'll be in 5 and I will go between 2 and 5 because Johnny's in 2.
Mm-hmm.
Open all rooms. Oh, sorry, Chris. I'll assign you to a room. And I will assign you to a room, Liam. Room 3. Great. How was that?
That's good. That
Good.
won't be fun for the exam.
Diane, we struggled to find a nerve in that sample.
Yeah, we'll find it for you.
Thank you.
There was one there. But even if you let's say what would happen, for example, if you got this in the exam, you would have a photo and you would hopefully see a round thing with cells around it.
Yeah.
All right. Hello, everybody. Thank you. Welcome back. I think we might just be waiting for Amanda's group. There we are. Okay, great. So should I share, Amanda?
Sure, let's do that. Yeah, we had a bit of trouble with slow lag in our room, so it'd be good to go over it. It took us a little while to get to the crux of the matter.
Okay, so I really liked the way that people started with the normal tissue to get that was really well. All right, Amanda, where would you like me to go?
Okay, can you just rotate that so that the skin is at the top, because I like to work from the outside to the inside. Okay, so what I can see, starting at the top, I see epidermis, dermis with hair follicle, sebaceous, then there's subcutaneous fat, and then there's a layer of skeletal muscle. So I think we're around the eyelid, and then there's another layer of fat, and then we go down into some deep purple material, and I can see blue all around the outside, which looks like surgical marking ink. So that will be the edges of the lesion, and whatever the lesion is, it goes all the way to the ink margin. But I want to know, what is this? Where are we down here? What's that? What's down there, Diane? Oh yes, these pinky, dense pink areas. Well, in the middle of the field, that looks very regular and organized glandular structure. Looks like a gland with a duct in the middle. So this must be lacrimal gland, I think. And there's a little bit of inflammation. So there's a big duct where the tears come out, and the acini are where the tears are made. But surrounding that, it all looks abnormal to me. So some patterns that I see here are tubules, glands, and then there's this fabulous one that looks like a lotus root in cross section, which is a cribriform or sieve-like shape. And I'm looking at the intersection between the normal lacrimal gland here and the surrounding tumor, and I think this tumor is invading and infiltrating and destroying the lacrimal gland here. It's behaving in a malignant, invasive manner. So I think this is malignant. I think it's gland forming, and it's got this cribriform pattern. And even at low power here, I can see there's two colors. There's this pink material, basement membrane material, and then in the other area there was blue flocculent material. I think this is an adenoid cystic carcinoma arising in a lacrimal gland. And oh, look at that right in the middle there. I can see like this target going round and round and round. If I go into the bullseye, ding, that's a nerve. So there's perineural invasion. And adenoid cystics do a lot of perineural invasion. So I have to look for, so I've made my diagnosis. I don't have differential. My prognostic factors, perineural invasion is one, and the other one is surgical margins. It's at the margin. It's incompletely excised. So I would comment on that as well.
Other people have described grade in the past. It's not really very important as a prognostic margin, as a prognostic feature.
Yeah. Questions? Is there questions? Type them into the little chat window. I've lost my chat window. See if I can find it again.
We will just also discuss the fish of MIB. Not that you did in this case because it's so classic, but it is a marker of adenoid cystic.
That's right, yes. Ancillary studies might be useful if it's less differentiated.
Yep.
Do you want to say that again, Bridget, or type it into the chat for our learners? I don't know
I think
why.
the BCSC says that P53 has a worse prognosis and BCL2 and BAX have a better prognosis. Is that true?
It's probably true. People have probably done studies on it.
In a research setting.
I don't use them. How
No.
about Chris? Do you use
Chris, do you
We,
use them?
No, I don't use them. The only other discriminating factor would be a solid pattern, where this tumor looks completely solid. That's said to have a worse prognosis, solid variant.
And that might be a bit tricky to diagnose.
To
so
diagnose.
That's when the fish
MYB
for MYB would be
comes in.
really good. Yeah.
Okay, let's move on to the next one. I'll keep you in the same groups and I'll stop sharing. And we're going to the second of those two Lacrimal gland ones now. Pop you back in your chat rooms.
It's the AAO Zoomify one.
Liam's still unassigned. Liam, I'm putting you in with Amanda.
Sorry, yeah, something was funny with my thing. I don't know.
Yeah, so I'll move you to room 3. Okay, so that was that one. For a bit of a shake up, should we hand it over to Bridget and Chris to talk about that one?
Oh, fab.
Are you feeling okay with that, Bridget?
Bridget, you want to speak?
Oh, Bridget is screen sharing. Therefore, Chris is navigating. Chris is talking.
All right.
Oh,
So
can you go full screen, Bridget? It's at the bottom of the, it's at the pop out, the bottom, go along the menu all the way when it resolves, almost at the right hand end of the menu. Yeah, that one. Yep, good. Thanks.
right, so Bridget is pointing out some normal lacrimal glandular tissue. It's got a lobular pattern. It's got large ducts in the middle. And then these acini that she's pointing out, which are regular structures that produce the secretions. And then she's targeted on a well-circumscribed mass, which appears to be encapsulated. This tumor shows a varied growth pattern with these lightly staining bluish areas, which if you look at it, looks a bit like cartilage. If you had a section through a epiphysis or something, it would look similar to that, where you have this, you have these.
Chris, that's too hard. This is ophthalmology, no epiphyses here.
Cartilage often has cells in spaces, and then this bluish matrix, which is just the stroma in between. So we've got this chondroid material, and you'll notice they're fairly uniform cells. There are no mitoses or anything. Then we've got the more cellular areas that Bridget's pointing out now, punctuated by glandular or duct structures. On a higher power, we're trying to see what are those ducts lined by.
Yeah, I did read in the book there was meant to be 2 cell layers, but is it true?
No, you've got to go to the right ducts, but they're definitely 2 cell layers.
Yeah, we found some with 2.
There's maybe one.
Yeah, that's quite good.
That one's good that you add. So you've got the inner layer, which is cuboidal, and it's got a bit of small amounts of eosinophilic cytoplasm, and then surrounding it are darker staining cells with regular round nuclei.
What are the names of the 2 cell layers? What are they made up of, Chris?
Okay, so you've got your inner epithelial layer, and then you've got a myoepithelial layer, which you can think of as being like the contractile part of the duct. And those same cells, the myoepithelial cells, are drifting off into the stroma. And they can assume various patterns. They can look like plasma cells. They can look spindled. If we go towards the edges of the chondroid areas, you'll see some looking a bit more spindled there. And then also look as though they're forming that chondroid material. So what we've got here is a biphasic tumor, 2 cell types, epithelial and myoepithelial, with a chondroid stroma. So it's a benign mixed tumor. Pleomorphic adenoma is another term for it. They can be a bit difficult if you look too carefully at the capsule. It often bulges through, but it's not necessarily a malignant feature.
I have a question in the chat. Would you call this a pseudocapsule or a capsule? And can pleomorphic adenoma form either?
It's a moot point. What is a capsule and what is a pseudocapsule? You know, as something grows, it compresses the fibrous stroma around it. I think most people would say this is a pseudocapsule. It's not really well defined. That's another area of the. You often have this tumor bulging through the so-called capsule.
Like little, what do they call them? Pseudopodia?
Pseudopodia.
Yeah, little feet coming out.
These can be malignant on occasions. Most of them are benign, but that would be, you'd see increased
Yeah.
cellularity, necrosis, mitotic
Yeah.
activity. You know,
Too
we're
rare.
not seeing any of that.
We'll just stick with the
Benign,
standard PA.
pleomorphic adenoma.
Okay.
And the PLAG one for fish or immunohistochemistry.
Oh, should we write that in the chat, Bridget? What's that? Can you write that down in the chat? The fish that we could do if we were not sure. Although this one's pretty obvious, so I don't think I'd bother doing any fish. Would you do any fish for this, Chris?
No, I think it's one that looks fairly straightforward.
Okay, thank you very much. I'm just going to move us along in terms of time, and I will show you. Right, so what we're going to do next is we're going to move on to
Alexa, isn't it?
next section. Here we go. So we're looking at non-tumor globes now. Okay, so there's a couple of videos here in case you have forgotten the structure of the retina. I expect that you haven't, but pathology registrars, you might want to view those. And then we're going to look at key histological findings in glaucoma. Look at 2 slides. Key changes in diabetic eyes, 2 slides. Okay, so let's keep on going here. And key histologic findings in glaucoma. Oh, that's diabetes. What have I just done?
Oh, just the link directly above it, isn't it?
Oh,
Yes, yeah, above it. There's no space in between. No, down one line.
oh, this one. Did I click the wrong one? Diabetic eyes, PowerPoint. Thank you. Thank you.
Oh, you're doing glaucoma?
Oh, I'm doing glaucoma. Oh, I put
Yeah.
the wrong link in. Never mind. We're
No,
going
no,
to.
it's just above. It's just above. It's this. See, there's 3 lines. It's the first line, and then there's a Google Doc. There, that one. There,
one.
glaucoma. There. Ha.
For my electronic incompetence.
That's all the lines are squishing together. Okay,
All right.
good.
Okay, so what's going to happen now is we all know that posterior histology is very much the same in any glaucoma. So my approach to a glaucometer slide is to work out whether it's in fact glaucoma by looking at the back first, right? And you can do that at very low power. You will be able to see, hopefully, in any slide at low power, a nice cup. And then once we've done that, these are just from the textbook, we'll be able to see the nice things that we need to see. The widening of the subarachnoid space, the thinning of the nerve fiber layer, the gliosis, and the loss of ganglion cells. All right, so this, I just want to say thank you to Dr. Leon who did this. What is this called? What's B? Anyone in the chat? What's this? What are they saying it is, Amanda? What's this? What's B? I showed you this. Yes, that's right. Schnabel's optic atrophy. So it becomes so atrophic, little gaps and cysts just form with fluid in the optic nerve. All right, what's missing here in the chat? Yeah, ganglion cells. That's right. Ganglion cells are missing. So it's hard to spot when things are missing, but they're definitely gone. And these little cells left are the astrocytic cells. They are not ganglion cells. Notice that this has got it's separated, but it's got intact rods and cones here. And people were asking me yesterday, how do you tell the difference between a true and an artifactual exudate? Retinal separation, and these are intact. So this is artifactual. All right. Let's have a look here. All right, so this is looking at all the structures in the angle. I am sure that you know them well, don't you? Yeah. Okay. All the clinicians will know this, pathology registrars, that there are lots of kinds of glaucoma, at least 12. But the first thing that we do at the front of the eye is decide whether the angle is open or closed, right? And then we decide, usually it's open in most glaucomas. Sorry, usually it's open. Yeah, forget that. In open glaucomas, we then have to work out why the trabecular meshwork is being plugged up. So on this one here, what do you think the pathology is? Why is the trabecular meshwork being plugged up? We've got an arrow pointing to this thing here, and we've got these cells here. What's going on? The angle's open. So someone thinks it's phacolytic glaucoma. Yeah, so that's great. And yes, this is macrophages with degenerate protein in them. And we'll be able to see them all through here, but in particular in the trabecular meshwork. And this is the clue here. We've got this empty sac of a lens. Now, if we had this is the lens, all right? And here we've got some cells here, here, and here. What kind of glaucoma would we be thinking of here? It's the clue is these cells here in number 2.
So not all inflammatory cells are the same. Like
No,
number 1s look very small, and then number 2s look rather larger.
that's right. And Matt is telling me that this is phacoantigenic glaucoma. And we have a granulomatous reaction to the lens because the capsule has been ruptured. The lens protein is causing a granulomatous reaction.
Is that a giant cell up there, just sort of above the
Just
number
here?
2? Yeah,
Yeah.
that one, multinucleated giant cell.
Is
That's
the
quite a goodie.
epithelioid histiocytes
Mm,
with the giant cells. These look a bit like newts, actually.
neutrophils.
Newts, and
Is-
then some lymphocytes out here.
Is this the same as phacoanaphylactic?
It is the same as phacoanaphylactic.
Oh, they've changed the name.
All right. What am I showing here? What is the problem here? So Melvin tells me it's PAS. This is a lovely pink stain for Amanda and I, but I suspect Melvin means peripheral anterior synechiae. We can see that here we've got the trabecular meshwork, the canal of Schlemm, and the iris angle should be back here, but it is not. Okay, so this is what you're going to see in exfoliation syndrome on the front of the lens. You've got these little Christmas trees of the exfoliation material, and you will see it. There's the Christmas trees even better. You will see it also in the trabecular meshwork. You will also see it bringing pigment with it. And so the thing that you might confuse it with might be primary open angle glaucoma, because that also has pigment in the trabecular meshwork. So as soon as you see pigment, think, what could it be? Could it be melanomalytic? Could it be due to, iris epithelium rubbing on the lens? Could it do exfoliative or POAG? Don't forget traumatic glaucoma. So there's 3 things that can give rise to glaucoma after trauma. Right. Traumatic eyes are really hard to work out because everything's disrupted. So I usually start by finding something to hang on to. So the ciliary body is always pretty recognizable. So is the posterior iris pigment epithelium. So then we realize we've got ciliary body. We've got this kind of munted iris here, and completely torn away at the base is this iris root. And there's a whole lot of blood around, which has probably entered the trabecular meshwork. Okay, what do we think is going on here?
Something's not in the right place.
Here's the
Mm.
trabecular meshwork in the canal of Schlemm and the scleral spur. What's the problem? Angle recession, that's right. So it's about recognizing the normal structures, and something isn't in the right place, and it turns out to be the angle. All right. So you might get questions about congenital, infantile, or juvenile glaucoma in the questions, the written questions. You will not get them in the pictures. Okay. Why? Because they're really hard. But what you probably have to do with those is you have to be able to use the keywords that describe them. All right, so let's have a look at hemolytic glaucoma. So again, we've got pigment in the angle. Hopefully, there is evidence of bleeding into the eye. Why is it brown? What's the stuff in these cells, and what are the cells?
Melanin.
You've just failed, Amanda.
Looks like melanin to me. You told me it was brown before.
I know, it's hemosiderin. All right, so for extra
Oh.
points, this is the special stain that we're going to use to show that this is not melanin.
Hard to tell sometimes.
It is.
See, I fell into a trap.
It's, and you can't use, like, immunohistochemistry is terrible with brown things because it's often brown. What stain? Prussian blue. Right, all right, pearls. Yeah,
Yes,
Prussian
yeah.
blue. So this will turn the iron blue. Okay, so we're just going to go. So melanomolytic is also gives dense brown pigment here with the pigment in the macrophages, and then there in the trabecular meshwork.
How do we know they're in macrophages and not in melanoma cells?
Well, they might be, they're that brown. Yeah,
hard
it would
to
be hard
see.
to tell, wouldn't it? Yeah.
Yeah. In fact, the special stain that I would use would be bleach.
Bleach, yeah, bleach. We can bleach out the pigment and see the cells better. Okay. Right, so the other thing that trauma gives is epithelial downgrowth. So let's look at the normal things that help us. So here we've got the ciliary body and the dense iris pigment epithelium. And then what tissue is this growing along the front here? What is this?
Just looking in the check. Yes, Matt said stratified squamous. Well
That's
done.
right. So this is stratified squamous epithelium. Yeah. Okay. And then here we've got ice. So what's growing along the front here and closing off the angle? Yeah, endothelium.
Endothelium.
And membrane material. Well done. Right, and we can look at it by looking at the PAS. Okay, neovascular glaucoma. So there's several things that will give you a clue that it's neovascular glaucoma, and you don't really need to go closer than this power to get them. So I look at this and I notice the angle's closed. So we've got anterior synechiae, which suggests that there's been new vessel formation. I then look at the very flat surface of the iris. So the ironing board iris will give you a clue that it's been pulled flat by contraction of new blood vessels. The ectropion here, right? And here we can maybe even see some new vessels growing along the surface. They can be tricky to spot. So normal iris vessels have a very distinct kind of basement membrane around them, whereas the new vessels are very thin along the top here. Okay, so here we go. This is neovascular glaucoma. We'll just ignore that picture. Right, primary open angle glaucoma, we all know the angle's open, we have pigment there. Sometimes there's inflammation in the angle, right? And it gets plugged up by inflammatory cells. So if you've got iritis, for example, several things can happen. You can get anterior synechiae, but you can also just get inflammatory cells that are present and cause glaucoma. Right, so that is a very quick run through so that you don't forget what we're looking for. So where do we look first if we think it's glaucoma? In the chat? The back. That's right, the back of the eye. And if you're writing a question on glaucoma, right, don't forget to talk about the back of the eye. I've seen people get so excited about writing about changes of exfoliative glaucoma that they just write about the front of the eye, write about the back of the eye as well. Right, here we go into breakout rooms. You are going to do the first globe for glaucoma.
Yep, number 1, secure AAO.
Oops.
No, it's just us. The lens had some cataractous changes in it.
Yeah, sorry, I accidentally clicked leave. Abandoned the.
All right. Oh,
Everyone else is not done yet. How did your group do, Chris? Did they get to neovascular glaucoma?
Yes, they did get to that, but they were trying to trick me on etiology of it, looking for other changes, which I couldn't really work out.
Right. Well, that was fun.
All right, who's going to
Shall I share or
you share and I'll talk?
Yep. Just pull that over there. Is that still sharing?
Yeah.
Yep. Okay.
All right.
I'll just make that big.
Okay, so looking at low,
Right.
I can see a few things. I can see that there is a cup, and I can see even at low power that the irises are flat and they appear to be shortened, and I'm suspecting that there's anterior synechiae. So going to the back of the eye, looking for the generic changes first. If we could go in about 50%, Amanda.
Okay, about there.
Yeah, so I can see that there's blood there, which might suggest some fragile vessels had been broken as we come through. I can see that the optic nerve isn't quite cut through the middle, but even from here, I can see a whole lot of fibrous tissue in between the optic nerve bundles. And that suggests
what does that mean?
that means that there's been dying off of the nerve fibers of the optic nerve and replacement by fibrous tissue.
So optic nerve atrophy.
Optic atrophy, yeah. As we come a little bit closer to the optic disc. All right, so here we think that there's been neovascularization, and we might want to start looking for some new vessels. Now, new vessels are hard to spot, and I didn't actually spot any really good ones here. Often they look like little chains of pearls going off into the vitreous. All right, so the next thing that we're going to do at the back is we're going to confirm that it is in fact a glaucoma by looking to see what's happened to the ganglion cell layer. And I look at the nerve layers and I go 1, 2, absent.
0. So what have we got here? Outer ganglion, outer nerve.
The layer in the nuclear ganglion cells absent. And
no ganglion cells.
An artifactual detachment because the photoreceptors are preserved. As we scoot along the retina here, I'm looking for any signs that might give me a clue as to etiology. I'm noticing that I can't particularly see any vessels. It looks a bit disorganized there. And the reason
atrophic looking, isn't it?
Pointing it out, it looks very atrophic. Oh, if we just stop and zoom in there, it could be where people have had laser, it becomes very disorganized and you get proliferation of the RPE and you get movement of pigment into the overlying retina. So even though we can go and look at the RPE, sorry, that's retinal pigment epithelium to pathology registrars. But this pigment and disorganization suggests that this person has had laser peripherally, which would suggest that maybe this was a neovascular glaucoma. Can we go and have a look, Amanda, at the choroid and retinal pigment epithelium in that area, please?
Okay, just adjacent to it, it's not on the slide.
Oh, well, not useful, is it? All right. Okay, around to the front here.
So oris arata coming around, ciliary body, ciliary body, ciliary body, and scleral spur probably about there. Yep.
So we do have anterior synechiae, a flat ironing board iris, no ectropion, and we do have pigment on the anterior part of the lens, which would suggest that there's been some iris touch happening there. Let's go and look and see if we can find any new vessels in that angle.
Yes, this leaflet is a good one to look at. What about these big vessels here?
I like those. They're normal.
Mm,
Central iris vessels are normal, but here on this leaflet, I can see a little chain of vessels along the anterior surface. So this confirms that this is neovascular glaucoma. I couldn't see any changes that led to a specific etiology here. The iris pigment epithelium isn't particularly lacy. It doesn't mean it's not diabetic. It just means maybe he had his blood pressures under his
mm,
sugars under control for a while.
mm.
All right, so that was my assessment. The lens was quite interesting. I probably brought you back slightly too early to look at the lens, but I think the lens has got some changes in it. I think this is a cataractus lens.
Mm.
There's lots of little bleb formation here, right around the cortex of the lens, particularly under the lens capsule. So this is an old lens. Can't see much fibrosis, but it is breaking down.
Degenerating. Yeah. Okay.
Okay, so questions now, please. I think you all did that one really well. I've been impressed by the preparation of people. They're able to, my groups were able to recognize changes really well.
Mm,
And
good.
kind of make a sensible differential diagnosis.
All right, I'll stop share. There's no thing. I just have to step out for a minute and receive somebody at reception, so I'll be back shortly.
Okay, should we use the same groups and go on to the next glaucomatous eye? I'll pop you in your groups, okay? So much to eye pathology, isn't there, Nicola?
Yes. A lot more than I know currently.
Okay.
We're
Which of the
back.
geologists would like to talk about that one?
I can have a go if you like, Diane.
Okay, thank you. Should I drive?
Yep.
All right, I'll share my screen. There we go.
Okay, so we can see a cross section of the eye, and you can see it's quite a nice cross section because we've got a nice view of the. Is this the right slide, Diane? Or is this the?
That's
The
the
one-
previous one.
That's the
This-
previous one. It's not this one.
We've done that one. So
Yeah.
Yeah, let's not do that one. Let's do this one.
that one.
Yeah.
I need my 5-minute break.
Yeah, it's coming up.
Okay, so this is a much better cross section of the eye. You can see a very nice optic nerve at the back there, which shows evidence of some optic nerve cupping, which tells us that we need to consider glaucoma. If we go up and have a look at that at a more higher power, you can see the nerve looks like there's a little bit of nerve atrophy. There's some more pink acellular hyalinized areas, but I'm not seeing a lot of neovascularization within this nerve fiber.
Mm. What do you think of the arachnoid space? It seems quite.
It seems quite wide. It's the nerve
wide.
seems a bit thin. Yes.
Yeah, the nerve's shrunken down and it's very narrow rather than flaring out like it normally does.
Yes. Yes. So if we go now and have a look at a bit of the anterior eye, now that we're considering whether this is glaucoma, let's have a look and see whether we've got an open or a closed angle.
Yeah. Okay.
So looking from this power, it looks like we've got a nice open angle. We're not having the closed angle with the iron board irises like we saw before. So it looks more like an open angle. And I can also see at this power that there are changes within the lens. But let's go and have a look at the angles first, and then we'll come back to the lens. So within that angle, I'm seeing these foamy histiocytes or macrophages, which seem to be filled with lens-like material. Again, I'm not seeing too much neovascularization within this. And the ciliary body looks like it's got a little bit of inflammation, some lymphocytes within it. But I think the main changes are these foamy histiocytes within the angle. So if we go and look at the lens to see if there are any lens changes to account for that. So with the lens, the nucleus looks quite sclerosed, and there's lots of degenerate lens material around the outside, and the lens capsule looks like it's quite loose. So I think this probably represents a phacolytic glaucoma.
Good. Any questions in the chat? I thought this was a nice case. Thank you very much, Bridget.
The ganglion cells, sometimes they're there and sometimes they're not.
Ganglion cells, yes. We looked for ganglion cells around the fovea here, and we could count 3 layers. We thought 3.
Yeah. They were quite abundant in some
there.
areas. Yeah.
I always go and look here, because we know that the peripheral vision is lost first.
And here there's not so many.
Many, yeah.
So it's a differential loss of ganglion cells in the peripheral iris, but preserved around the fovea.
Yeah.
Okay, good. Yeah,
Good.
because around that fovea, they're like
Tons.
really thick and juicy looking ganglion cells.
Any
They've got
questions in the chat,
whole
Or-
eye.
or just yell out to people?
Or chat. Lost my chat window. Hang on, there's one in the chat. Was that an artifactual capsule breach anteriorly? Oh
Yes.
yes, that square chunk that's come out. Yep.
Yep.
Artifact. Good.
Oh, is there anything else? No. All right. I suggest we come back at past.
Mm-hmm.
Drink
have a
lots of
break.
coffee. Drink lots
Stop
of
your recording.
Yeah, stop recording.
Thank you, Bridget. Thank you. You're
Get up from your desk and walk around. Very important. Okay, see you at past the hour.